At the outset, I thank the Institute for me. I always like to come here and whatever we are able to share, the knowledge, the skills, I always take this opportunity to come here and do the same. And that's how a lot of activities are being carried out at our place. And it's nice to share those activities. So before coming to this important topic of labor care guide, I would like to show some of the things which are related to this topic and how usually maternal health is being catered so that the quality is maintained and women's satisfaction is improved. When we were residents, these aspects were not there in discussion. Okay, women used to come and we used to just cater delivery services were delivered. There are many things over the years, over the decades rather, things have definitely changed, and we cannot have same mindset which we used to have 40 years back, 30 years back. Now today, the expectations of the patients, expectations of the government, expectations of the community have changed, and we have to really change ourselves as an obstetrician, as a maternal health care provider, so that they are satisfied. Today, we talk it as a maternal health care delivery as a woman-centric care. What she wants, what she deserves, what she expects from us, we should be able to deliver that type of care, and not what we. So it's not a doctor-centric care. It's no more a doctor-centric care. It's a woman-centric care, and that's how, with those changes, even WHO has modified its partograph. They are not calling it as a partograph, they call it as a labor care guide, but they also say that it's a next generation partograph. So subsequently they might start saying it as a partograph, but now they are saying labor care guide. It's a guide. All those rigid boundaries or limitations of the partograph have been removed for various reasons that we will come across during my presentation. But they call it as a labor care guide. Labor, simple labor, care is care, and guide, so their guidance. There is no hard and fast that you strictly should follow this. There can be variations. Flexibility has been kept while we cater the services, or while we monitor, or while we give intrapartum care. So we go ahead with, so I bring greetings from my institute where I am working now since the last 35 years. And this facility is a Laksh Manyata certified facility. And we also have International Childbirth Initiative, which is an international body which is actually started by International Federation of Obstetrics and Gynecology, that is FIGO. And there is similarly for nurses, there is an international body, ICN, International Nursing Confederation of Nurses. Okay, so they came together and thought that together they can do something good for the well-being of the mothers and well-being of the babies, newborns, and then they formed that ICI. So we have got a certification of that hospital also, that body also. And also we work with White Ribbon Alliance, which is mainly working for respectful maternity care, okay, RMC. So even on the site of this White Ribbon Alliance, Crown Institute of Medical Sciences logo has been put, because we are part and parcel of this particular organization. Coming to, when we talk of quality of care, the number determines the quality, okay? So higher the number, quality becomes a challenge, and that we are facing day by day. But in spite of those challenges, how you can further stick to quality parameters, how you can improve the satisfaction of the women, that is very important. It's a challenging task, but it is required. In whatever limitations, whatever challenges, whatever facilities are available, we should try to cater the services in such a manner that quality is improved or quality is maintained. So we have around more than 10,000 deliveries per year, and there was a felt need that from the traditional care, doctor-centered care, we should go for a collaborative care Collaborative care means we take help of other allied branches, sciences, in order to improve the quality of care. Now, allied branches for us or the partners for us are nursing. Okay, nurses who cater services of only maternal health are called midwives. Okay, not only previously we used to call midwives only catering the delivery services, but that concept is no more there. It's a continuum of care. Antenatal, intranatal and neonatal or postnatal services is a continuum of care. So those midwife, which is Government of India is starting a new cadre in itself, which is for BSc nursing candidates, and after that they will do 18 months of a specialized course in maternal health and then they become midwives. So they are also part and parcel of our services, and that is what is they are important stakeholders of the collaborative care, and of course patients, their relatives are also part and parcel. So collaborative care models is a patient-centric models or approach in which we do take consideration of the values, preferences of the woman we are delivering. One important thing maybe from today, stop calling pregnant women as patients. Try to do that, try to improve on that. They are not patients. It's a physiological process, physiological situation or status, and don't call them as patients. Call them by names, call them as pregnant mother or pregnant women, but don't call them patients. By calling them patients, you are going away from physiology, you are thinking about pathology. Patients are diseased persons, pathological conditions, suffering from pathological conditions. So, pregnant women, call them pregnant, okay? Pregnant women. Mothers, would be mothers, but not patients. So that is one thing. So that is the patient. That itself shows a respect to her. That calling her a patient is, I will say, as a disrespect. She is not suffering from any disease or disorder. Okay. So patient-centered care, team-based care. It's not only doctor, but give equal importance to nurses who are equal partners of our maternal health services. Then comes the improved outcomes, and when we do this collaborative care, definitely outcome of the patient satisfaction and also the maternal and child health outcome is also improved. And of course, we keep the plans flexible. We should not follow particular protocols. Problem what is happening? Why a lot of discussion about obstetrics and midwives, why midwives are coming up, why government is thinking in that line? Because government feels that obstetricians are doing good job, but at the same time they are not differentiating between low risk women pregnancies and high risk pregnancies. They are implementing all the protocols of high risk to low risk, also started implementing, and that is why the operative interventions have improved, increased. There is more medicalization of pregnancy. There is another terminology which is used, medicalization of pregnancy. I will give you examples and you should agree with me what is this medicalization of pregnancy, and that is what is, we are talking today of natural birthing. We want natural birthing, which used to happen. It's a totally separate area which I am not going to talk today. But I would definitely like to come because it's I am passionate about that aspect of our speciality. That I will come later and talk to you. But today we will mainly concentrate on this labor care guide, which is the topic for today. When we think of, somebody said about the partograph, which is initially it was only a cervicograph, only two lines were there, that is the cervical dilatation and the descent of the presenting part, and slowly changes started happening. It was a WHO partograph, then modified, it itself modified. The difference between modified and original partograph was latent phase was considered in WHO, and they used to start this thing on maybe 2.5 to 3 centimeters. Then came the WHO modified partograph, which we are using presently. And even the government of India today is talking about and even implementing modified WHO partograph, not LCG. We are not, although at program we have started LCG, use of LCG, but government of India is still asking us to follow, means their government public health facilities to follow only their modified WHO parthograph. Lot of studies are being conducted, and WHO has also approached us for collaborative pilot study on LCG, which we are about to start. Now, the difference, all those technical or the clinical parameters that we used to monitor in parthograph are there in this also, LCG. But what government thought or the WHO thought that these aspects are equally important but not being considered at all when we document labor process. Okay, and those parameters have been added into our LCG, which we will talk about. And of course, the important component being respectful maternity care, RMC, and also taking the woman into confidence when we take any decision. Many times when we were residents, things were happening automatically. No consent, nothing. Forceps being applied, ventouse being applied, episiotomy is rampant, and C-section only paper, put sign and OT. So that used to happen, and at many times, many places, that is same thing is being happening. That is not correct, that is not accepted. Okay, and that's why that those changes, WHO thought that it is must that we should change, because when we say WHO means it becomes a apex body and we just blindly follow or we have to follow. But then they thought that if we are only given that, and if that is the reason why people are not doing, so better apex body only gives or modifies its parthograph so that people will start thinking and start doing it. That is the main purpose. And of course then they have added respect to her, giving autonomy to her, privacy, and ensuring confidentiality. So these are some of the aspects of the woman-centric care that WHO is expecting us to do. Women's perception about her birthing experience is very, very important. If the woman is happy with whatever service, type of service, quality of service she got, then she will come for the subsequent deliveries for pregnancies to you. If that is negative, she will never come. Same thing, if she is happy, she will tell 4 people. If she is unhappy, she will tell 10 people not to go to this hospital. So that is very important, and that we have never considered that what is her expectation, what does she feel. We never took any feedback from her, and that is the time WHO thought that we must change. So these are some of the women's expectations, that what type of quality of care should be there. So what mothers want? Mothers want dignified care, they want privacy during whatever interactions that happen in the hospital, maybe antenatal, intranatal, postnatal. They want a trustworthy team, respect, quality, and of course autonomy. She feels that yes, my opinion must also be considered while certain decisions are taken. Today is the era of reproductive health rights. People are talking of, which was again never we thought, reproductive health rights of the woman. That's why there is a lot of controversy when she says that मुझे सीजर ही करना है. तुम कितना भी उसको समझाओ, but वो she is confirm on her decision. Today you cannot say no. Whatever you feel that she had normal delivery previously, but she maybe some bad experience she had, but now this time she said मुझे सीजर ही करना है. You tell her, you do your duty as a doctor, as a counselor, but you will have to do her section. So that is what is her autonomy. It is a reproductive health right. Other areas where reproductive health right comes into picture is a medical termination of pregnancy, tubal ligation, contraceptive advice. Everywhere her opinion has to be considered when we take certain decisions, and that's why one of the important sections of that labor care guide is shared responsibility, her autonomy. Talk to her, explain her what is her opinion, what does she feel, you give your inputs, and ultimately what she feels has to be followed. Whenever these decisions of instrumental deliveries are taken, we never took any side. We felt that we are doing for her benefit, for her well-being. Why we need to ask her? If we don't do it, baby will die. And we used to apply forceps, ventouse. Today, it is not the case. If they come to know that this thing has happened, they can sue us. And then there are all the medical legal issues start. So that is the era. That is this. We are working in a very different era. That's why all the postgraduates, interns, maybe another 10 years things would be further different, and we have to be extra careful whenever we are providing any maternal health services. when we talk of joyful birthing, that we want that women should be happy. Ultimately, our aim is this: you should be happy. Aim and objectives of antenatal care. Those 2-3 words is without any complication to the mother and baby. She should be happy. Okay, she should be, whole experience should be joyful. So we need to know what is her experience of her birthing, what were her expectations, whether those expectations are fulfilled or not, what does she feel now, is she satisfied? These aspects are ignored. These aspects we do not pay attention to, but that is not the case. We must pay attention to these aspects, and then only we will say that yes, she was happy, our services were of good quality, and then she will tell people that yes, go to this hospital, go to this doctor, you will get good quality of care. So that is about joyful birthing. And of course, when we talk of quality of care, which again I am involved too much these last 3, 4, 5 years, quality of care, when we say for the joyful birthing, we must see that the services that we provide must be effective, efficient, equitable, without any discrimination, in a timely manner. We must sit into OPD, we must be available into the wherever in the wards. Otherwise, once after the rounds are over, patients say that they have relatives have a lot of queries, and then nobody is there to solve their queries. Same thing used to happen in our hospital. Now we have 7 wards, 210 beds for OBGY. So we have, if not residents are less, but then we try to find out another alternative, asking another allied health professionals to sit there. So in the form of a ward manager who looks after when residents are not there, busy somewhere else, they are available for communication between patient, relative and the doctors. So they must be satisfied about the overall quality of care. Our availability has to be there. We should be there whenever, for example, appointments are given. People come from long distance, and then we must see to it that we are available. Continuum of care, I have already said that pregnancy, labor and postpartum, all 3 should be there. We should not just limit our quality in during pregnancy, but it should continue with the labor and also postpartum area. Who are the stakeholders when we talk of joyful birthing or the patient satisfaction? Of course, we are there, our nursing staff is there, then relatives and mothers, they have also got some responsibility towards positive outcomes. We try our best, and then they are not willing to, or the compliance is poor, the outcome may not be satisfactory, may not be optimum. So they are also the stakeholders in the whole process. And at our place, we have also there is a constant communication between pediatrician, because all medical colleges are high risk pregnancy, have high risk pregnancy units, and perinatal counseling or maybe communication between these people is very important when we take certain decisions, mainly operative decisions. Of course, for this also we need to have support from the administration to bring any change, and these are the people who at our place are involved into this decision making. And in addition to, when we talk of holistic care these days, it is not only your technical obstetrician care, but there are many aspects of care which can be catered by this. If you see this chart, there are many things which there are some certain things are little hatke for my department. Like we have started a dental chair in the obstetric antenatal care, where all the women undergo oral hygiene examination by the dentist, qualified dentist, on a dental chair, so that all the issues related to oral hygiene, which we say that important. So primary screening of those oral hygiene is done, and if they find something wrong, then the specialist care, they send it to dental college specialty. This is little away from, but otherwise lactation counselor, Ayurveda experts. Now today's topic is not that, but then we are starting with the birth preparedness classes, and also classes where there is a mindful where women who have some psychological problems, they are also catered, and yoga classes have been started. So a lot of things have started, for which we have all this team of people. These are our collaborating partners for giving best quality care. Okay, so we come to our topic, Why I said because the main difference between our regular partograph, what we are using, and this LCG is involvement of the woman in decision making, relatives in decision making, that is the shared responsibility. And of course, supportive care is one of the another session, another part of the whole LCG monitoring that we will see. That's why I thought that first I will give you a brief about what is expected today from the team who are giving services to women. So this WHO has certain recommendation on intrapartum care for positive childbirth experience. Positive childbirth experience. When she leaves your hospital, she should have positive experience. To whomsoever she has met, from security officer at the entrance till the mama mausi who she had some, who helped her in the whole during hospital, during her period of hospitalization. So all those people have some responsibility, so that if everyone is in the same level, then only, otherwise you give best quality doctors, nurses, everybody is trained, and mama maushi is shouting at her, asking money from her for the services she is catering, then she will talk, and people talk negative more often than any talking positive. Negative outcomes spread very rapidly in the community. Positive outcomes go, but it takes more time. Negative, within days, the whole negative message will spread in the community. So it requires more time for us to build our reputation and trust with the community. Okay. Even something has gone wrong, it will last for months together in the community before again we catch up with the previous whatever workload you have. So that's very important, that intrapartum care, postpartum care, woman and the relative, whole family. It's a concept. What I said, the ICI, International Childbirth Initiative, they don't talk about only maternal outcome, maternal, child, and family. Family also they have included. What is the family's perception about the quality of care? They were waiting outside. They are taking pharmacy service, lab service, this service, that service. Whole, overall, comprehensive, total experience of the family is important, and family takes decision. That woman is not taking decision about where to go and what not to do. It's the family. So family members also have to be satisfied about the quality of care that is being provided. You cannot ignore them. They are sitting outside, but they should have some program to involve them. Otherwise, just women coming inside and then the relatives. Sometimes that day I found 2-3 boards which I noticed for the first time. Purushanna Pravesh Nahi. Purushanna Pravesh Nahi. OPD Purushanna Pravesh Nahi. Labor room. You may restrict the entry, but don't put a board Purushanna Pravesh Nahi. Oh, they will stop coming to hospital only. It's a Purushanna Pravesh Nahi. With the male HOD. Purushanna Pravesh Nahi. In no time, I removed those boards. Today, it's a gender sensitive. It is gender equality we are talking about. Neither, both the genders, you cannot just restrict someone. You have your cultural norms, but doesn't mean that you put a board Purushanna Pravesh Nahi. That is not accepted at all. It was removed immediately. Okay. You can have restrictions. You can, whenever some consultation is need to be done for example, infertility evaluation, this evaluation, operative delivery, with our norms, you have to discuss with the husband and the parent. Purushanna Praveshna is what Purushanna Praveshna. Okay. So that cannot happen. We have to work with everyone, with the male partners. There are the programs for male partners also, which we started recently. It's not going on, but whosoever are sitting outside, we used to take them in the demonstration room, and separate PowerPoint was prepared, and we used to just deliver them. What is your role of males in the reproductive career of the woman or whatever reproduction? Okay. That includes bringing that pregnant mother to hospital regularly. One example I am giving whatever medications have been prescribed by the doctors, to bring those medications. If blood in an emergency, if she needs transport, arrange transport, accompany her. If blood is necessary, donate the blood. At least see where is the blood bank. Although that is their role. We need to tell them during antenatal period that this is your role, not sitting outside. This is your role. You have made your wife pregnant. Okay. This is your role now. Whole role. We have gone to extremes like cutting a cord by a husband in the labor room. Okay. And then he is also holding the baby, and that first contact is also developed, rapport is developed. Although we have cultural norms and certain restrictions of the labor room, but then we tried and we took her with all the mask, face, and this cutting the cord. That is how you begin their involvement into the reproductive. Otherwise, he is away, sitting there. काम झालं का मला फोन कर, मी येतो चहा पिऊन. No, you sit here, see what is all happening here, get first-hand experience, and when it will be your turn, your job, something has to be done, you should be available. So that is what is the childbirth experience we are talking about. And then, of course, LCG. Now, labor care guide. There may be certain, sometimes we feel that this is for whom? Is it for PHC? It is for RH? It is for district hospital? It is for medical college? At what level this LCG is to be used? WHO clearly says that it is for all the levels or all the types of health facilities. That includes our medical colleges also, because the component, there is nothing type of specialty, type of health facility wise parameters. Everything is applicable everywhere. So it is for medical college, district hospital, everywhere, even a private nursing home. If they maintain this, all the medical legal issues they will be able to sort out with no problem, because chart says everything has been done, whatever could have been done for that case, and it gives a clean sheet to you if the chart is maintained. These days, sometimes the charts are maintained retrospect. That is a different story whenever there is some mishap. But if it is done, it is for good. It is for good for the patient well-being, doctor's well-being, society's well-being, everybody's well-being. So that has to be done. So message is, it is for all health level facilities, and when it should be initiated. Now it is for the first stage of labor. Now again, there are certain differences between the partograph that slide I will show you afterwards. But you all know that our existing partograph, we start plotting the graph from 4 centimeter dilatation onwards. But here they say 5 centimeter dilatation. This is the first difference. Another difference is, of course, only in the present partograph, only the first stage of labor is been put. Even the second stage of labor is not involved. Whereas in now modified this LCG, second stage, what happens in the second stage, that is also been monitored and documented. Okay, so this is the difference between those two parthographs. Then where should the labor care guide be used? That I have already told you. Now coming to the structure of the WHO labor care guide. We have given you a copy of this, which you must be aware about the different sections. I have given you copy so that you can have a close look of those sections which are there, and they are very simple to do. And 7 sections in that. First section is, of course, First section is, of course, identifier, which was there in our regular partograph also. Not only the identification like patient's name and maybe parity, but what were the findings at the time of admission? When she got admitted, what was the findings? Whether she was in active labor or not. Now this partograph, we will call it as partograph only. This partograph is, even if the patient has come in latent phase, we will not immediately start. When she will enter into the active stage, that is according to them 5 centimeters, then only we will start plotting it. Again, the question comes that does it mean that we should not monitor during latent phase or till she is 5 centimeters? Absolutely no. She should be given due care, attention, supervision has to be there, because although the problems that arise during intrapartum are in the latent, in the active phase of labor, but latent phase is also very, very important. There could be sometimes prolonged latent phase, there could be rupture of membranes, and even some, if the baby is descending, there can be fetal distress, if the cord is around neck. So all those, but according to this, only after 5 centimeter we will start plotting it. So before that, all the findings of our examination would come into our regular case sheet till 5 centimeters. Subsequently, all the findings can come onto this sheet. Once you are using, if you are using this, the work is quite less. All those time-wise, everything, again and again you are writing everything, that is not required. After latent phase, only single sheet of paper is sufficient to show, to document your findings. Maybe whenever your lecturers or whoever is coming, if they see the well-maintained LCG, that would satisfy them and that will reduce your paperwork, writing work, and it is a good medical legal document. So it is better we learn. This you see that in the top, although we took it from WHO's, it's available online, but we got it printed in our hospital's name and we have started using. Again, we have to again and again tell the residents about its importance, and otherwise again it becomes, it goes out of use. So first part, section 1 is identification of the patient or the mother and her how was her onset, are there any risk factors. Now subsequently, second is the supportive care. I would like to say a little more about the supportive care because this is an added component and it was not there. Although we were part of it, we were doing, but there is no documentation of that is happening. And that is the reason WHO thought that yes, we must document. And those all 4 important parameters, one of them first being labor companion. Okay. Now Government of India, as per Laksh guidelines, they have made it compulsory to have a labor companion in labor. There are many reasons why labor companion there. We have also learned through our some bad experiences. Okay, of not having labor. Maybe last time whether I was told or not, one session I already had here on this. But labor companion, first degree relative usually of the woman being there with her throughout, from the entry of her into the labor room till she goes out of the labor room with the baby. Labor companion is there. Okay, why we made it 100% compulsory with some incidents happening which gave a lot of headache to us, whole team, whole hospital. In a busy labor room, in absence of labor companion, one day baby got swapped. How? One woman was getting delivered, the nurse was there, resident was there. Immediately one woman came into second stage of labor, baby on the perineum. The nurse who was standing there immediately shifted to that woman when she was taken on table, and she took that baby because it happened within seconds of minutes. And she put that baby into one of the newborn corners trolley. And this, for whom she was waiting, within 2-3 minutes she delivered, and she also took that baby, and same nurse took that baby and put them into newborn corner. Now what happened? We usually hand over the baby at the gate. Now we have put this thing camera so that there is proper handover. Now both the babies almost same time, so same time they were taken out, and now the babies were getting handed over. And usually they bring a cloth, the relative bring a cloth, cotton cloth, and the 2 relatives were standing outside, 2 babies with nurses inside, and first baby was getting handed over to first relative was standing with the name being called, and the first the relative was taking the baby. She said she took the first baby, but the person was standing behind for the second baby. She said that cloth is ours. That orange cloth is ours, in which first baby was getting handed over. So confusion started. Baby is handed over to first. One male, one female. One of the relatives was engineer. Couple was engineer couple. Okay. One preterm, one baby went to NICU. One baby was okay. We went to general ward. Cloth. She said that is our cloth. Why you are giving that baby to them? Baby, the second baby was given to the next person. But confusion started, halla gulla started, this. They were Diwali days. The matter came to ultimately, there is no other way to sort out this problem other than DNA. The lab for us is DNA is in Nasik, and the lab was closed for 4 days during Diwali vacation. And all those four people along with those babies need to be taken the samples, blood samples, 6 samples to be taken to a government lab for DNA, and then thing would get that 4 days you have to take care of all that halla gulla in the labor room area. Okay. And one baby is becoming sick and sick in the NICU, and all that happened. On 4th, 5th day, the samples were sent, and we came to know that baby was actually exchanged. So with that DNA report, under everything, the babies were handed over to respective. If labor companion would have been there throughout, this would not have happened. From that day, as a HOD, labor companion has been made must. This was pre-COVID era. During COVID, again, there were some restrictions, but now labor companion, the time she enters into the labor room, she goes even to the newborn corner. She's in, nowadays there is no concept of first stage and second stage. Okay. But then she is throughout in the first stage, second stage, still the baby is being cleaned and taken care of by the neonatologist or the pediatrician. And when it is to be handed over, during this whole journey, labor companion is there, so that there is 100% security as far as swapping of the baby is concerned. So these are the aspects we have to keep. Of course, this is one example why I took a lot of interest being a HOD's headache for sorting out those medical legal issues. And then a lot of people figure out what is happening. Then this type of messages go into the community. किसको किसका भी बच्चा दे देते ये दवाखाने में मत जाओ, किसको भी किसका भी बच्चा दे देते, हुआ है ऐसे यहाँ. This type of messages, if they go into the community, it will take long time to rectify those issues. That's why again we have taken care of all those issues. But that is why for us labor companion is important. But of course it is said that she is very important component for physiological and psychological support to the woman. Lot of that's why we made do's and don'ts. It's not that anybody is entering and then they don't know, they're just sitting talking on mobile and calling here and there. And so there are do's and don'ts for the labor companion put in bold. We have pamphlets in Marathi language which I can share with you, that what they are supposed to do and what they are not supposed to do. Don't interfere in our management. Okay. Don't do frequently in and out into the labor room. So there are certain norms, they have been explained to them. A Marathi pamphlet is given to them so that they follow that, and then only it is useful for us. Their presence is useful for us. Okay. So that is also another important component why labor companion has to be there. And then of course the second important issue is pain relief, which is another totally ignored area. डिलीवरी है तो पेन तो होता ही है, पेन तो सहन करना ही चाहिए उसने, क्या विदाउट पेन कैसी डिलीवरी होगी, that type of concept. And that's why pain relief has been totally ignored. Many women, maybe I don't know about your labor room, but many women run out of the labor room from labor table just because of severe pain which they are unable to tolerate. Individual pain sensitivity is not considered. Individual woman has her own pain sensitivity. If she is really unable to tolerate, she is going to run away from the scene where you are trying to push her and asking her to sit and sleep there on the one bed. So pain relief, now there are different ways of pain relief, which all pain relief today available in the medical colleges I have kept into labor room, including Entonox and the epidural. And of course, there are non-pharmacological methods of pain relief like a birthing ball, and there are many aroma unit, music therapy, distraction techniques, psychotherapy, these, that, which are all made available. So pain relief, so that all the issues of women running out of the labor room because of pain, that is tocophobia, has come down. Okay. Labor companion is there, mother is there, sasu is there, somebody is there to take care. Pain relief has been provided. Let it be distraction technique, but something. Okay. So that is importance of pain relief in labor. Oral fluids, and there are a lot of wrong practices of keeping them NBM and every woman coming and getting an IV line. There are certain reasons for putting IV line. For our setup also, we thought that we should restrict it, but many women come from long distance and then they are sort of underhydrated, and if they develop some complication, they suddenly go into hypovolemia and all those complications. That's why those practices of putting IV line. But again, that is not they say what WHO recommends is plenty of oral fluids should be given. And if she is in latent, give her a light snack that should be prescribed. Do not keep them nil by mouth. Keeping them nil by mouth is a first step of taking them for C-section. चलो nil by NBM है, चलो NBM है, कोई problem नहीं. There only you have started thinking that she is for C-section. No. Posture is another important, very important, and today a lot of talk and discussion is going about the ambulation during first stage of labor, and posture, whatever. It's not only the posture, but many places in a busy labor room, once they enter into the labor room, they are given one bed, and then she's confined to the bed, and she has not to get up. If she gets up, तुला काय कळत नाही का, तुला किती वेळा सांगितलं उठू नको, कशाला इकडे तिकडे फिरते, and then what not, disrespect, another issue starts, is disrespecting her. So today ambulation. So we first must know what is today concept of supportive care, her expectations, then only we change our practices. She is allowed to ambulate, she is allowed to be upright, that is helping her, the baby, to descend down, shortening the labor course, reducing the pain relief measures, need for pain relief measures. That's why she should ambulate. Places where there is no place is okay, but we have a very large corridor where we ask them to ambulate. We have kept the birthing balls there. They can hold the bar and they can do that. But that has to be encouraged. Nurse or the doctor, whenever we should encourage, go out and walk rather than sleeping here. So that is what is posture. Allow her to take posture whatever she wants to. Do not restrict her ambulation. Do not ask her to be lying down in the supine. Not only in the first stage, we have even gone to all the postures in the second stage of labor. That I will come later and talk to you about what not we are doing. So that is what, that supportive component which was totally missing and actually needed something to be done. That's how it has actually, after identified directly, first section is only on supportive care, because WHO thought that this is really rest of the thing, dilatation and medication, that is happening, but this is what is not happening. First address that issue. That's why supportive care in the form of companion, pain relief, posture, and oral fluids. Oral fluids, they are saying, they are not doing give diet. Oral fluids, liquids, give liquids, clear liquids, whatever she wants to have, give liquids. Then of course baby is the second section, which I will first we will just cover this and then we will go horizontally. Second, baby, they are same components that are there in our regular partograph about the basal fetal heart rate. Then there is about the whether there is any deceleration, whether there is any amniotic color of the amniotic fluid, fetal position, okay, caput and molding, okay. The next column that is above that is written alert. I will tell you about this alert subsequently. But these are the parameters of the baby and mother. All the parameters which were there in our partograph, like pulse, systolic BP, diastolic BP, temperature, and urine. Okay, so those are to be monitored on regular basis. How frequently, that I will tell you. And of course, then comes the two important parameters regarding mother, that is uterine contractions, that were also there. Number of contractions and duration of each contraction, which is a regular feature of our regular partograph that has to be monitored. Now that is to be done, again that I will tell you later. Then comes the labor progress and the important changes into this. What are the changes than the existing partograph? First thing that I said, that we start monitoring from 5 centimeters and not 2.503 which was original, and then now they said 4, but here they are saying 5 centimeters. Okay. So if you see in that cervical plot, it starts from 5, 6, 7, 8, 9, 10. Okay. Now, our even textbooks today, they mention about the progress of the sort of assessment of the progress of cervical dilatation. We arbitrarily say that if she is a primary gravida, 1 centimeter per hour and 1.5 centimeter per hour in multigravida. But those things have been removed. They say, WHO says that they have studied 10,000 women and studied what they have studied, what is the progress of labor in those 10,000 women. They found that there is such a wide variation among the progress of those 10,000 normal deliveries, 10,000 normal deliveries, that you cannot really have, you cannot say that 1 centimeter and 1 point centimeter, there can be 2 centimeter, there can be zero point 0.2 centimeter. Do not have those rigid guidelines. अभी 5 घंटा हो गया, अभी उसको तो कुछ भी progress नहीं, no nothing. That's why if you see this in front of that centimeter, they have written for how many hours we can wait for that centimeter. If you look at the chart for 5 centimeter, they have said that even if she stays 5 centimeter without any maternal and fetal abnormality, you can wait till that time. 6 centimeters you can wait for those 5 hours, H is hours, and that's why that 1 centimeter per hour, 1.5 centimeter, that has been removed, that is no more concept. But if maternal and fetal parameters are normal, that is, we know what are those important parameters, then we can wait. Do not be rigid as the timeline. And that because of that rigid timeline, lot many operative interventions have been carried out in the active stage of labor, that she is not progressing. And then if you look at our one chart in our areas, that is Fernando areas, high risk pregnancy, in the abnormal uterine action, there is a chart saying what is protracted first stage, what is secondary arrest of dilatation. All those terminologies are being used, and they have given 2 hours, 3 hours, 1.5 hours, whatever that. Those are our, that is obstetrician written textbooks, which we followed for years together. But now WHO says that even after so many hours, if other parameters are normal, you can wait. If the time is only the issue, you don't be in hurry in time, neither you augment the labor. Even if there is a delay, do not put Pitocin, do ARM, that is also not recommended. Reduce medicalization of labor. Wait, have patience, you will get the results, positive results. So that is about the cervix and the dilatation. They have removed that 1.5 centimeters. Descent of the presenting part, which we, in the original, it was sort of a zero station, -3, -2, 0, 1, 2, 3. That is what was there in our partograph, or it is there in our partograph, which required internal examinations. That is a station in reference to zero station, which is ischial spines. But here they have removed that. They are measuring it in per abdominal examination. They don't want too frequent internal examination for obvious reasons of infection, discomfort to the woman, and unnecessary things happening there. So descent is to be assessed. These days, residents forgot the art or the skill of assessing descent of the presenting part per abdominally. If I ask who invented, who started, hardly anybody knows about the names, because you're not practicing that. That area where your hands used to be there is been taken by a belt that is doing that monitoring, fit heart monitoring. If we ask, so what is 3/5, what is 4/5, what is 2/5, when to call the engaged head, very few residents, even in the final examination, are able to answer. That is a tragedy. WHO, understanding this tragedy, said that let us put it into per abdominal examination assessment of the descent of the presenting part, 5/5, 4/5, 3/5. Don't every now and then duty change, next person, internal examination. Why? Because we don't believe in the previous person's findings. She doesn't know, he doesn't know, and I want to confirm. I am responsible for these duty hours. I have to inform my lecturer. I must know. So do it per abdominally. Tell it is 3/5. Tell your boss it is 3/5. So that is why this descent is a change. This is a change. Per abdominal palpation, descent. Then comes, of course, medication. That is same. Whatever medication you give, whether it's oxytocin, enter same. What units, what drip rate, you have to enter. Okay. And of course, then IV fluids, if at all you have started IV fluid, let there be mention about the IV fluid. There are many other medicines which this natural birthing process does not permit, which is also part of excessive medicalization of the labor. Those drugs, smooth muscle relaxants in the form of epidocin, buscopan, drotin, these are the three culprit drugs which are rampantly being used just to augment course of labor because she delivers early with cervical tears, and then you take her to OT and then give blood transfusion and disturb night. Okay, so these three drugs are not there, should be there in the labor room, but judicious use of this medication. At my place 10 years back, the residents started mixing all three drugs into syringe, 10 cc syringe, and interns started pushing this drug every hour, chota chota dose. When I went for surprise visit at night time, I found this. What is this syringe? What is happening? Nurse tell that, sir, this is what is happening. Three drugs together, cocktail, buscopan, epidocin, drotin together, 1 ml every hour. This is what, and then the practice so-called under table practice. Meso under table, not documented, we don't come to know. Now, madam, I am 35 years now. So, you're nodding of the head. Okay, we understand the issues. And that's why we suddenly land up into complication. And we know that this cannot happen without this. But there is no proof, there is no evidence that it has happened. Underground meso, underground, under table, meso. Okay. And then some big colporexis, and then running here and there. Okay. Few years back, I went to Hyderabad, where there is a Fernandez hospital. Some of you might have heard, and there is a Fernandez team is very good. It's a maternity unit, corporate hospital, maternity unit. Once I just went for 2 days just to see how they function, how we can take something good and take it to our place. There I heard that they have stopped using prostaglandins. Serviprime also they stopped using. Why? I said Serviprime, without prostaglandins, our labor room cannot work. Whatever, at least induction of labor, MTPs, without prostaglandin. No, we had one maternal death due to prostaglandin, and that's why we stopped using. Even today, Fernandez Hospital, one of the reputed institutions, has stopped using prostaglandin because maybe erratic responses are there. I also experienced erratic response in my own relative, where in no time there was such a rapid dilatation and big cervical tear. Rajendra's wife, Nigal, Smita Nigal, such a big, the cervix became, when I explored, it was almost 2 to 3 inches long. 2-3 inches is 7-8 centimeters with a tear. So erratic responses are known. That's why when you have a doubt about whether to use or not, I use half dose. Okay, and if she accepts or if she is tolerating or there is no issue, then we can give another half or maybe full dose. But prostaglandins are known for erratic responses, and one should be careful. Otherwise, whatever has happened at Fernandez can happen, and there is a maternal death in a corporate hospital. It's a big issue. Okay, so that is about the medication use and its entry into this. And of course, last component which needs to be really, again, I already talked about, is shared decision making. That is totally number 2, that is supportive care, and this shared decision making is another area where there is need of improvement in everywhere, every hospital, because we are not inclined towards communicating, timely communication with the relatives, through the patient, explaining her, okay, what are you going to do, why you are going to do, what is going to happen, pros and cons have to be told, take their due consent, put it in writing. This space is written there. You write it down, that explain to her, and then whatever is the plan for that particular thing to happen is to be explained. Now these are the 7 sections of the LCG, I have explained them. Now let us come horizontally. Okay. On first 3/4 part there is called as active first stage, and the second part is the second stage. In our regular partograph there is nothing like second stage. There is no, what ultimately happens in second stage, there is no mention. We used to write in some corner about the baby weight FT, ND 2.8 kg, this, that, or if the patient is shifted for section, LSC has done, and this and that. But now here they have mentioned about the second stage, if there is a prolongation of second stage, or if there is some instrumentation, or all the monitoring of the second stage. If the second stage there are mishaps, we have no monitoring happening. So there is a documentation of the events happening, monitoring of the events that have happened in the second stage. Same, all these parameters, 7 parameters are monitored for the second stage in this LCG. So that is given. Many mishaps are due to in the second stage, many more. So we need to have some monitoring that yes, fetal heart was there. I do get every month 2-3 calls or information that everything was fine, but there is a FSB. Now, FSBs are a big headache. If there is a unexplained FSBs, especially fresh stillbirths, nothing. Partograph is happening. The tuck is also happening, but there is a FSB. There could be reasons, whatever reasons, but then if we have monitored, it is documented, then at least we have something. Yes, we did monitor. If you just say that no, it was good, we saw it, and she also heard. Okay, so that is not accepted. You have to have document. Okay, let the court say that no, this is a fake document, but there is a documentation. So this is the horizontal part. Now coming to the one column, vertical column, again I will explain you where they have written as alert. For all the components of individual section, whether it's a companion, whether it's a supportive care, whether it's a baby, in that alert column, they have given a norm. When to call it as that parameter as abnormal. If we take, for example, baseline fetal heart rate, that is the parameter, they say call it as an alert that if that finding subsequently which you are going to write in the blank areas, if that finding, your observation is beyond that parameter which is given in the alert, then it has to be once you document, it has to be circled. Okay, if for example, if you find that fetal heart rate is 100, you put 100 in that blank area where time and make it circle. Why you have made it circle? Because it is as per the alert. Okay, it is as per alert. If we take another thing like pulse of the mother, they have given a 60 to 120 is a permissible range of the mother. But if it is 50, if it is 125, then it's an alert, so that some action has to be taken by the concerned person. So make that, if it is a 122, write 122 and make a circle so that it's an alert. That subsequently, because if it is an alert, it will have something written in the assessment that you found a fetal bradycardia or tachycardia or maternal tachycardia, and some plan has to be there for that. You explain it to them. So for each and every parameter, a range of normalcy or abnormalcy, when to call that parameter as abnormal has been given. It's a sort of a ready reckoner. Just looking at it, is it normal? Is it abnormal? Whether we should report, whether I should report to my lecturer on call that yes, madam, this is she is having fetal heart rate is last 2 observations are 100, 90. I need to report. So, and whenever you put it abnormal, normals are not to be circled. Only abnormals are to be circled, so that our attention will go to only circles. That this is a abnormal, this is abnormal, this is abnormal, and then we take appropriate action for that abnormal finding. So that is an important change that is not there in our modified WHO partograph, but here they have given the normal range of individual parameter, and that. For example, that companion, pain relief, oral fluid, posture, they have written N is, if it is not there, companion is not there, is an alert. Pain relief not given is an alert, N. Oral fluid, there you will write N. If in that blank area you will write N and then you will make a circle. That pain relief is not been given. She's shouting, no pain relief. Then down below there will be medication. You will give medication. You will talk. She will ask. She might ask, why you are giving? What is this injection? Why you are giving? Explain. Your pain relief. This is a pain relief measure. It will help you. So that has to be there. Birth companion is not there. Call. Where is your birth companion? Call the birth. Once she comes, then you write Y. Okay. Low down, all these, what is N, what is Y has been given in very small letters. Okay. Like an index of all those alphabets have been given. Oral fluids, if she's not, they are only alerts. N is no. She's not taken oral fluids for previous class 4 hours. Write N and then below give oral fluids. Ask relative, companion, nurse to give oral fluids. Okay. Posture. SP is, she's supine, lying down. 4 hours she's lying. Now also she's lying. She has not gone out. She has not walking. No upright. No birthing ball exercise. Nothing. She's supine. His SP is alert. So write SP. Write N if they are abnormal. Make a circle and then corrective steps. And all other below are our regular parameters to say whether it is right, or whether it is within normal range or not. Okay. Coming to all those small squares. What are they? How frequently we have to do? So all those are in hours. Like above, they have written time and hours. Whenever she comes, 9 p.m. she has come, right? 9 p.m. That is hour number 1. Okay. 10 o'clock, 10 p.m. becomes hour number 2. So there you have to write time when she has reported. She has reported at 9:30. Start from 9:30. 10:30, 11:30, 12:30. So 1 hourly that has to be written. And below that 1, 2, 3, 4, 5 will just tell us that how many hours she has completed since she has come to us, or when she has gone into that our active phase of labor, right, after 5 centimeters. Okay. So active first stage and second stage. Now some of the squares or those squares have been further broken. Okay. That you will find. So all those squares are 1 hourly. So all those supportive measure findings have to be written or documented every 1 hour, whether she has taken some fluid or not. Okay. Posture, has she gone into done oral fluids or not? But further down, those baseline fetal heart rate, that is further divided into 2 parts. So those parameters have to be documented, assessed and documented every half an hour. So fetal heart is to be documented every half an hour. If you go straight away into the second stage for that, it is further broken into 2. So fetal heart to be monitored in the second stage of labor every 15 minutes. Okay. So during first stage, fetal heart every 30 minutes. It is further broken into half, that is every 15 minutes. So that's how those lines are those. Similarly, contractions are to be monitored every half an hour, whereas in second stage, every 15 minutes, you have to make a record of those. Okay. When it comes to descent of the presenting part, again, descent of the presenting part, they have mentioned about every half an hour. Okay. So this is how the 7 sections of this partograph are monitored, and then this chart has to be put into the individual case file. Below is the initials. Accountability is very, very important. When we are monitoring, maintaining, documenting, who has documented this? Many times duty change. Morning hours, 8 o'clock, whatever, 7 o'clock, 9 o'clock, you are giving handover. When this chart is being handed over, or maybe it is put into the file, you must know who has documented. Residents have changed, faculty has changed. Okay. So initials are very, very important. It gives accountability of that person, who was there, who has observed this, who has documented this. That is the account. For the accountability purpose, those initials have been put there. Okay. So this is about the different sections. I will just rush through this. This is how, if you see that there are those small red things, you will find. Okay. These are the circles because they were abnormal things, observations. And something, whenever there is some abnormal, Below down you will find something is written and some action has been taken, or it has been explained to the relatives, and some communication has taken place. So this is how it will look like. Uh, First, I repeat, identifying information and labor characteristics at admission, supportive care, those 4 parameters have to be written. Then care of the baby, baby's 6 parameters are there. Care of the woman, 5 parameters are there. Labor progress, I repeat, that don't be very rigid as far as the timeline is concerned. One important thing which I have not told you, all that alert line and action line has been removed. Alert line after 4 hours, similar oblique line, action line. Once the action line is crossed, something really has to be done, action has to be taken, and we know only one action. Rasta towards operation theatre. That has been removed. That is an important reason for increasing in the C-section rate. Action line is crossed. Action line is crossed. C-section. That has been totally removed. Rigid timeline has been removed. Do not follow that. That is the important thing which I did not tell you. You don't find those 2 lines, alert line and action line, into this. Medication, I already told you, shared decision making is another important which has been added. So supportive care and shared decision making, these are 2 additions. Other 5 things: introduction, mother, baby, cervical progress of labor, medication, contractions, it was there in our original partograph. Okay. So they say that what actually we are doing in this, we are first assessing, means observing. We are assessing the case, then we are recording, documenting. First you go to patient, assess, what are the findings, record. Once you record what you are finding, check with the reference threshold. Third thing, check with the reference threshold, that vertical column. And depending on that, compare labor observations. And then plan what is to be done. What is to be done? If those circles, abnormal things, what is it? So assess, record, check with the reference threshold, and plan according to your observation. So this is what we are doing in this labor care guide. This is readily available online, all this. So now what we have done, I already talked to you about the Friedman's curve, which was there when we used to be students, then WHO partograph, then came the modified, and today we are talking about the WHO labor care guide. Now, brief revision about the differences. Okay, there are 10-12 points. Modified WHO partograph, and these girls tell me that they had a DNB question this time on this, the LCG. Okay. Labor documentation begins at 4 centimeters in our regular partograph, whereas it is 5. Documentation, we have only first stage, where here we document even the second stage. Labor progress graph had alert line, action line, no action line, no rigid timelines. There is no provision of monitoring, documentation, supportive care provided to women. Those 4 things, that is not there. Here it is there. Graph consider expected dilatation of cervix at the rate of 1 centimeter or 1.5 centimeter. That has been totally removed in the modified WHO partograph, LCG. Then graph does not document and monitor shared decision making. कुछ बताया नहीं हमको, ऐसे ही कर दिया, और ये तो हमको तो बताया भी नहीं, फॉस्फेट लगाया बच्चों को इतना, ये सब क्लियर हो गया, ये हो गया, वो हो गया, डॉक्टर ने कुछ बताया नहीं, हम मना करते हैं, हम सीधे बोलते हैं उनको. There is a documentation, and then accordingly consent would be taken. Consents have a great role. Each and every instrumentation, also we should have consent forms and take due consents. There is no provision of putting initials of a healthcare provider on the graph. They have made provision. There is no reference available in the form of alert values for the observations. There is a given the just threshold, alert threshold line, that is important. Progress of labor is monitored through frequent internal examination with 0 station as reference point. During now and then internal examination. program mainly through a per abdomen examination to find out how much of the head has entered the pelvis in terms of fits. Okay, very important. It is difficult to identify the abnormal course of labor as compared to LCG. It is easy to identify labor abnormalities and thus decide course of labor action as observation crossing alert values are circled. Okay, so these are the main differences between our. So a lot of activities we conducted, and I will show you. We conducted our place for doctors, nurses. We went to some other place, and also this is your last workshop at Nagar some time back. Time is there. So Nashik also we went, Yevla. So this is all about the labor care guide and the different 7 sections, importance of each and every section, difference between existing partograph, labor guide, labor care guide, what are the advantages of this being used as a routine. You are having an advantage of using this because of a little limited number of deliveries. It is doable for you. This becomes little difficult even for my available manpower, that busy labor room. uh, I'm not saying it's not doable for us also. It is doable, we should do, but at times it is not being done for the said reason. But here, it is definitely doable. Just try for 1 month as a small quality improvement project. The use of labor care guide as a small quality improvement project. Just check on day-to-day basis. If they have difficulty, just sort them out and give them a little more training about how to use it, supervise it, see that there is, again, thing is, since this is not an online document, again there is a possibility of doing it retrospectively. That is the drawback of this document also. But by little frequent supervision, and if the people are convinced about its utility or usefulness, definitely this can be a good tool to implement. Since yours is also not a government facility, there is no mandatory rules about use of the modified WHO partograph. This is going to come, but still there is no positive nod from Government of India. That's why some pilot study is being happening by WHO on LCG, but otherwise it is been promoted and used in many countries, many places, and we can definitely start using it with its benefits. Uh, we should use it with a positive frame of mind. Okay, not just for the sake of doing it. If we really this supportive care, shared decision making, rest parameters are okay, we also come to know. And here we are not following that alert line, action line. We are not following that rigid timelines of 1 hour, 1.5 centimeter, and this and that. Let us see what is our outcome. Okay, we can compare the natural birthing, and also you can devise a small feedback form about the um, uh, satisfaction level. There are validated tools to assess the satisfaction of the women who have delivered here, and then we can have better outcome, better birthing experience of the women. If we talk to them, ask them, we are not talking to them, we are not asking them, delivery ho gayi, discharge, third day, jao bhai ghare. But we are not asking. From that, we get some inputs also. That uh, we did that also when we started hydro labor facility. We took initial women only those who had normal supine non-hydro labor compared with the hydro labor. And how did you find? Okay. Similarly, we did for a stool, means a birthing chair delivery. Previous those who had supine delivery, now in birthing chair, upright birthing position. What is your outcome? Although we know that second and subsequent deliveries are always comfortable or the easier than the primary one, but still they give good, very good birthing experience when we make them upright rather than lying down supine. By जोर कर जोर कर जोर कर, एक ही आवाज आ रही लेबर रूम से, बाई जोर कर. And of course, I cannot stop here without telling you about the uh, disrespect in the form of a fundal pressure to just to
take the baby out somehow from the introitus, fundal pressure. Certain experience, I have long experience now. One of the resident, I'm open, one of the resident, maybe 10, 12 years back. Certain things beyond imagination. The 6 feet water long table, one resident sitting on the table. This is a woman, and then on the front side she's sitting and on the table, her feet on the table by the side of her head and giving fundal pressure. Can you imagine? Can you imagine? This type of practices go unnoticed if we are not vigilant in the labor room. One another experience of similar fundal pressure, I was in OT that day. Maybe I was associate professor or so, but then fundal pressure, and I get a call in OT that this is what has happened. Fundal pressure got revealed afterwards, okay, but the colporhexis, the tear going up to the left cornu, just because of the fundal pressure. And the hefty fellow, boy, resident, must be 75 kg. So these are the bad experiences I am sharing you. He gave under supervision, lecturer standing by, under supervision, old story, and till left cornu. So these are the practices sometimes go unnoticed if we do not really peep in, give surprise visits to labor room. And you should make the whole little, what we call vigilance. I have some nurses who are vigilant, and they privately will report me what happens in the labor room. Okay, vigilant. See, this is for betterment of the woman and the outcome and avoiding complications for which we are responsible subsequently. Okay, so we have to be vigilant. This is a very special branch. We have chosen by choice. It's our choice. Nobody has forced us to go into this. So we should learn only good things. There is a difference between us and the quacks and some other pathy people who are practicing this specialty. So we should be different from them by practicing only evidence-based medicine. Practice evidence-based medicine. Evidence go on changing. Today what is correct, maybe next year they will say no. Don't give sublingual misoprostol. Things would change. Now when WHO started from there to now they have come to this, there are certain evidence. They say 10,000 deliveries we are normally those removing alert line, action line, removing those 1.5 centimeter which they boldly wrote in the textbooks. Now they are removing that. This is a 10,000. Why you are doing that? They have experience and evidence of 10,000 cases. That is what they are saying this. So things would change, but then we should adopt the practices as per the latest evidence, latest guidelines, and follow that. So I stop here. If you have any questions, you are welcome.